All right, good morning. This is Senate Health and Welfare. It is February 27th. And we're picking up on some testimony that we were unable to hear Tuesday when we were on the floor for an extended period of time. So welcome, Craig. It's good to have you here. And before we begin, I'm going to have committee members introduce themselves, and then we'll ask you to introduce yourself, a little bit of background.
Senator Larry Hart, Orange County.
So San Luis, Old East County.
Ginny Lyons, Chittenden Southeast. Craig, thanks for being here. And I know we first met each other when you were directing the blueprint. So maybe you could give us a little background on who you are and your national interest in the work that you're doing.
No, thank you. First of all, thank you for having me this morning. I'm looking forward to the discussion with you all. And just, briefly my background, I'm a physician, but kind of stumbled into the world of working on developing healthcare program, now called population health initiatives, healthcare quality early in my career back at an academic medical center, Los Angeles County and USC Medical Center. Build an inner city asthma program, including at that time, the data systems and electronic medical record track, captive data aggregated, use it to drive a real population health system all throughout the inner city of LA. And that led to me being asked to come and run the Vermont Blueprint for Health in 2007. And so I did that and spent 10 years working on the Vermont Blueprint for Health program. Great team. And we had some really interesting advancements, challenges and advancements during that 10-year program. After that, I went on to work nationally, basically as a contractor and consultant with several agencies on national programs. One, the Office of the National Coordinator for Health Information Technology. I was on their state advisory team. We work with states all over the country and helping them on exactly this thing, the data aggregation, how to use data, how to build the infrastructure to do it. And then Centers of Medicare and Medicaid, the Innovation Center there, if you're familiar with CMMI, I became a contractor to them with they're a large contractor to help CMMI with their national data aggregation program. And that was data aggregation and data use strategies to support advanced primary care in their models around the country. So we worked on assessments in all the states that were participating in CMMI's primary care models. We evaluated their capabilities around data aggregation, and then where it was appropriate, where CMMI approved it, we actually implemented data aggregation programs in a large number of states around the country. And I think that's part of what led to this morning's discussion of what in Vermont can we do now to advance our data aggregation capabilities. But through that, I've had a lot of experience on advanced primary care, building advanced primary care programs, supporting them. And so I can also provide some insights and have tried to provide that to you, that things to think about for each legislation that you're considering preparing right now. I did leave on your desk and electronically an outline that contains some of the key elements for several things, including the data aggregation, but also advanced primary care, hospital budgets, some of the coordination considerations that you may have in the state, and some of the requirements you may have if you enter into a new value-based model, such as the AHEAD model, which is being looked at now. There's some essential ingredients that could be important to prep now for that. Yes.
Thank you for letting me interrupt you.
Sure, please do.
Have you seen the plan for a committee bill?
I saw the initial outline, and looked really good. And actually, it's really good framing of some of the key elements in there. And in fact, the considerations here were intended to help think about it.
Okay,
They were,
great,
yeah,
thank you.
some of the same.
And we've actually spent some time together having coffee, so it's great. Yeah.
Okay.
Yeah, so this should help
Yeah,
fit in or not fit into what you
Yeah.
produce as a bill.
It will.
So that's my background, and I guess I can start off with the data aggregation topic. I believe that was the.
Yeah, I thought that would be helpful. So that's been a place where there consistently questioned, so we'll begin with that, and then you can take your pick afterwards, because I know everything you say is going to be helpful.
So that's on page 2 at the bottom there. Yeah.
Correct. It starts there. And I'll get you right to the heart of it. I think, as I mentioned, it's actually been 9 years now, worked with CMMI on these data aggregation projects. And, I will say the evolution in CMMI reflects what states have had to go through too. They've grown and matured their program and their approach to data and how data is going to be used nationally in their models. I'm going to try and describe for you key elements that have been learned through that experience. So much so that now CMMI, instead of just doing data work to support a model, they did it model by model for the first years we did it. They're now building a foundational approach to data aggregation that can support all the various initiatives CMMI is doing across the country. Literally an advanced primary care program or gene therapy for sickle cell. They're spanning, they're looking at it as foundational. And it did take a while to get them there, but Vermont is really well positioned for a foundational approach. And that was what I was going to talk to you about this morning. So that experience really led to the development, as I mentioned, of a framework that can be used for planning, implementing, and actually monitoring. And I'm going to throw that out there, monitor the impact of your data aggregation program. This is important. It should be treated like any other program that you do. If you go to the next page, I'll just stop on figure 1 here, and I'll give you a sense of the key ingredients for really an effective data aggregation program. And again, this is adopted from a ONC framework that we then used for 9 years. I did help write the guide for ONC when I was working with them, but then we adapted it over 9 years with
ONC is?
Sorry, the Office of the National Coordinator for Health Information Technology. It's now changed. It's now a office within the Secretary's office in HHS. But at the time it was called, yeah. At the time, it was called the Office of the National Coordinator. But let me orient you to this picture for a second. So you'll notice 3 levels here. You'll notice at the base are things called foundational elements. Then you'll notice in the middle, the technical capabilities. And then at the top, the data uses and the services that should be key ingredients for a really good data aggregation program. We always tend often to think about these projects as technology projects. They're really not. They're building a utility almost, a core basic data utility. And in fact, many states are calling them health data utilities. They're building a utility. Yes, it has technical capabilities, but the reason it's successful is because it meets these foundational elements at the bottom. And it delivers something that is useful for providers. So let me walk you through that. The foundational elements, the things that are really important, and this is where guiding legislation can be very helpful. You'll see the categories of business reason, governance, policy, legal, financing, and data user support, learning networks. Those are foundational. If those ingredients are well done, you're going to find your state is going to find a way to make the technical capabilities work and deliver the right products. Yes.
Thank you.
Please jump in at any time.
Yeah, okay.
Just go ahead. I think, yeah, this is important to just
Yeah.
go ahead and ask your question.
Pardon my ignorance, but how does governance come into this?
Sure. So think about what you're doing in a data aggregation program. What you're really doing is you're asking people, providers, payers, community service providers, you're asking a lot of people to share data. That having them willing to share data means they have to have a meaningful input on how that data is going to be used, protected, and is it going to turn around and deliver something that really elevates what people do? Is it going to be a game changer?
Right.
So is there a reason to do it? And do they have meaningful input in? And that translates into the right governance structure.
And is there a level of trust? Parties.
The saying that we had in the programs around the country that people have done this really well is data moves at the speed of trust.
Right.
That's exactly the right way to think of it. And therefore the governance has to reflect that. So I pulled out 4 on the right side to just give a overview definition of them. But let me kind of walk through them and I'll get detail the governance item a little bit more. So first off, we got to have a compelling business reason. There has to be a business reason for people to be willing and share data because there's good reasons not to share data. You know, there's reasons payers are hesitant to do it. There's reasons providers are hesitant to do it. So there has to be a compelling business reason, and there are reasons. So we work with insurers all over the country. For example, I rarely met a Blue Cross or any other commercial insurer that wasn't willing to share data if the data aggregator returned a product to them that helped their business model. A leader of a data aggregation program has to have this. Give you an example. What do insurers want? They enroll new people every year. They need to stratify those people, understand their health risks. So what do? They go about trying to collect the past medical information on that person. Historically, they've done it by going to providers, asking for medical records. They've had to do chart reviews. When they turn in their quality measurement to CMS, which determines how they get paid it influences their payment from CMS. They have to go collect data. They have to create measurement from that data. They have needs for data use. You create a data aggregation that can, in one query, deliver. They can hand a roster to the data aggregator and in return receive the data they need for stratifying their population and doing the measurement. They're willing to share data and input. If you don't understand the use case, you'll have trouble getting payers to share the data. You have to build the purpose for them. Providers, it's the same way. They have compelling reasons to want to aggregate data and to use it to improve their quality, to improve if they're in a payment model. If you enter into a new payment model, like in the AHEAD model, and there's quality measurement attached to it, and that influences their incentives, they want to have the most affordable, straightforward way to reliable data. And the best thing, the places where this works well is when all those key stakeholders, payers, providers, are actually getting data aggregated data from the same source. They're working with the same data. That way they know that it's reliable and comparable. And so that you don't have different interpretations. Oh, our data says one thing, yours says another. So there are compelling business reasons that people will share data and work with it, and particularly if it saves them money and lowers their burden of collecting data. Does that help?
Yeah, and I like that there are business reasons. I also want to, highlight that hopefully the health outcomes are improved ultimately.
Correct.
I mean, that's the
goal.
That's what I'm interested in.
No, and of course, and I agree with that. And that's why we get into this and do it. So that the quality of the services and the care you deliver improves continuously. And in doing that, you improve the outcomes for the population you serve. But to get there, you've got to meet the needs of the people you're asking to share the data with. Otherwise, you get a fatigue after a while. If payers say, God, we're giving all this data, we're not getting anything in return, you get a fatigue.
Yeah, no, thank you.
Does that make sense?
Yeah, it does.
So when we talk about governance, and I'd like to highlight an example of that for you. There's a couple of things that you could consider, and this is something we address sometimes in guiding legislation. When you think about an effective data aggregation program, it's got to be multi-payer, meaning represent a population, enough of the population that people feel they can use it to change their work. It's got to be sustainable financially. Starting and stopping these initiatives, which has happened all over the country, including in Vermont. Starting and stopping initiatives is the best way to make sure it's not going to happen. Payers get fatigued, providers get fatigued, and they will stop participating in data aggregation initiatives unless they see there's a sustainable financial pathway. Well, for them to contribute and be part of a sustainable financial pathway, they have to have the business reason. And they also have to have a role in governance. Those ingredients have to be there in order for them to commit to finance the sustainable finance. That's how these things all tie together. So in governance, some things you could consider here in Vermont. I'm going to walk you through some specific recommendations. That you have someone leading this program who understands it's. Don't consider it a technical program. Don't consider it a data program. Consider it a program that, as you pointed out, is going to improve population health, quality of care, have an impact that matters. The people that lead these programs at Estate States in the country are the ones, they're often clinicians of some form. They understand services and care delivery. They also have the skills to understand how to use data and improve the operations and the quality of care. They understand how to look at measurement, interpret it, use it. These are cross-cutting people. They don't need to be the ones that understand how to build a master persons identifier or a warehouse with data lakes and JSON strings. The technical case, they hire people to do that. They get a contract. They got to understand the product that comes out of it and how to use it. So program leader is number one. Then number two, and again, a lot of these are clinicians, these people that do it really well and have some background in clinical services, quality improvement, understanding measurement and monitoring. They understand the products at the top of the stack, the data services and the data usage. The next thing is putting together a multi-stakeholder group that actually gives the opportunity for these key stakeholders, payers, providers, consumer groups to have meaningful input on the road of that data aggregation program. That stakeholder group, you know how many of these groups can be. Sometimes they're just advisory and are sort of passive and they come to meetings. The good ones have advisory groups where you've got all your payers, your providers, your key groups. Consumers are really important and they have meaningful input on how this program evolves and iterates over years, not just to start it and getting kicked up. So a leader that is, don't treat it as a data project, treat it as a program. Have a leader who understands how to build and use a real data utility and deliver services with the information and improve quality, and then have a meaningful advisory group and sometimes you have to formalize that. This is where guiding legislation can be helpful. The more I talk to program leaders like myself around the country that worked on this, a little guiding legislation leads to a more durable program, right? Because you're changing leadership every 2 years, every 3, incentives come and go, priorities come and go. We watched here with the blueprint, changes in the blueprints, data aggregation as leadership changed. They had some pretty strong capabilities at one time, and now they're going to have to rebuild those capabilities. So we've all watched it happen. It's not unique to Vermont. Guiding legislation can make it more durable, and I couldn't encourage.
I have a question for you. So you mentioned advisory group for this, different from governance. So.
Well, it's part of the governance. So,
Okay, well,
yeah.
it's part of the governance.
I would term it a leadership council almost, where they have advised really meaningful input to the, let's say this is embedded in AHS. This leadership council actually really helps inform the leadership at AHS.
Okay. And so, and then because what we have we don't have that in the outline. We don't have that advisory piece, but we do have that in the outline and in the initial draft that'll come forward. We do have an advisory group for the planning process to make it a ongoing, recurrent planning process. So you're suggesting we need something that keeps this moving forward.
Think of, and maybe this is helpful.
Here's what I'm thinking, because we don't want to build bureaucracy.
Right.
Our goal is not to build bureaucracy.
Right. Couldn't agree.
But I think what you're talking about is accountability and transparency and so on. So, okay. Okay.
So Senator, no, you're right on target. And when you think of governance, I'm really glad you guys hit on this because it emerged because this is so pivotal. Think of governance in a little bigger context than just the program leader or the director of the program. Think of a governance that actually informs not only the planning, the implementation, the ongoing monitoring, and the ongoing improvement. And to that end, a leadership council, advisory group, whatever you want to call it, that is formalized and called for and has meaningful input, is going to make it more likely that those participants stay involved in the program and don't fatigue. It's also going to make it more likely that a program within a state agency is
very constantly aware and attuned to what the needs are of the stakeholders that you're asking to contribute to the program. This is governance in its bigger picture. In order
Sounds
to
like
take
us.
Exactly,
Yeah.
exactly.
Yeah.
And it's such a core ingredient. And one of the things that we found that was maybe one of the more valuable things in this at CMMI level in data aggregation, we built a dashboard. We literally treated it like a program, and we showed the impact, the use, the adoption of the services. Some things don't get adopted that well. You dump a report with 50 measures on the desk of providers, they're not gonna look at it. They don't. The click rates, the adoption rates, the use rates are low. They're early and then they extinguish. You put a one-page snapshot that shows how they're performing compared to peers on a quality measure that is linked to the information they're getting out of the data aggregation. Their camera manager will pick that up and look at it.
With some graphics.
With some graphics, that's right. So again, the program leader has to understand that. And the leadership, the advisory council or leadership council, everyone that informs them has to make sure they stay focused on delivering products that are useful. And if you do that, you're more likely to have sustained engagement with your payers and your providers. And ultimately, you demonstrate value. That's how you get the payers I don't care if it's Oklahoma or Arkansas or Vermont, or Maryland. That's how you get the payers to be willing to contribute to the process.
Exactly.
Does that make sense?
Oh, no,
Yeah, that does make
actually, Senator Bullock and I were talking about something similar yesterday about how important it is to have everyone working together
Yeah,
to make things happen.
it really is.
Yeah, no, you're right. So, but I just wanted to make sure you knew that Senator Cummings is here. And,
Hi, Senator. Great. man.
you know,
Yes.
you probably know her.
We have met in the past.
Yeah.
Yeah. Haven't gone for a while, so.
Yeah.
Not gone, just not here. And what I did in this outline for you was then pull in a set of sub-bullet points that you may want to consider for the legislation. It touches on some of the themes that we're talking about, and I can just quickly highlight those for you.
Sure.
So, number one, you got to assure that this platform is going to have access to the data that is needed. And this gets back to your question about claims and clinical data. And I would argue there's a number of other data. One of the things that we found most valuable in national data aggregation programs was payer attribution rosters. Let me explain why.
What's what?
Payer attribution rosters.
Yeah.
So if your payer, Medicaid, Medicare, Blue Cross, any of them, are going to enter into a really good value-based model with you where they're going to pay primary care differently, for example.
Yeah.
They're going to pay capitated payments and maybe performance incentives, which is, a structure that's been used commonly. They have to know who they're paying on. So the payers are going to attribute. They're going to say, this person, Greg Jones, is attributed to this primary care practice. Therefore, I'm going to send my capitated payment to that practice. That's how they're going to participate in the AHEAD model or any primary care. If they can't attribute and know, how do they know where to send their money? So their attribution rosters, Blue Cross, Medicaid, Medicare, whoever else is participating, become the gold standard. And this is really important of who is responsible for that person's care. They're paying for it. They expect that primary care practice to be responsible for the care of that person. That makes that one of the most important pieces of information. And that's why I put it in the list here. So yes, claims data, yes, clinical data, lab tests, lab result procedures, diagnosis codes, all of that, medications, ideally, all of that critical. But if you don't know who is responsible for the care, the primary care of that patient, you lose accountability in the program. And you can't do measurement because your measurement, which you put out at the top of the stack, is going to be based on that attribution roster. Primary care practice X, here's your attributed population for the 3 payers or whoever's in it. And here's the results of the measures for the ones that are responsible for the care for each of you as payers. Attribution is critical. And attribution, I can tell you, in the places in the states where this has worked, gets refreshed and updated on a regular basis. CMMI sends the attribution rosters to the practices at least quarterly, often more, sometimes more, depends on the model. And then they send it to us, the data aggregators, so that we, data aggregators, have the same attribution roster as the practice says. Everybody knows who they're responsible for. That dynamic, that sets your ability in place to do it. So when you think about guiding legislation requiring if payers are going to participate in this program, I've listed out some of the key things, some of the key data types for you in here. Payer attribution is one. Payer socio-demographic data. Payers collect a lot of socio-demographic risk information that can't be collected easily in other places. When they enroll somebody, they know a lot about their medical risk and their social risk. That's how they risk it. That's how they risk stratify their population. Well, that risk, that socio-demographic information is very valuable in the data aggregation environment to help risk stratify for measurement, care delivery, and quality measurement. Does that make sense to you? So payer attribution, payer socio-demographic data, clinical data coming from Vital, and depending on the scope of connectivity, maybe directly from other sources as well. It's critical. You obviously, you want to be able to measure, you highlighted earlier, health status. Are people improving? Are they changing? You need lab results. You need diagnosis codes. You need test procedure codes. You need to know the care that was delivered to the patient, and you need to be able to monitor health status, blood pressure, basic parameters of people, measures of people's health status have to be included in that complete data. So you look at your sources for that. Vital is obviously, and HIEs are a natural source of clinical data. It may be that the aggregation group isn't complete enough and they need to work with some other clinical sources to deliver independently. The claims data, you asked about claims data earlier. We were talking about this and why is it valuable or not valuable? So one of the histories, and it's happened here with the VCARES, the All Payer Claims Database in Vermont. This happened with all payer claims databases all over the country. People delayed the use of that data because the claims, the payment for claims aren't fully adjudicated, often for 6 to 9 months. So by the time the data was ready, quote unquote, and used, it's 6 to 9 months old. And people didn't feel it was valuable. You couldn't use it for managing your operations on a day-to-day basis. And that's where the mistake was. The only thing that takes time to really adjudicate in claims is the payment, the final amount that's paid, what's actually determined to be paid. All the rest that an event happened, somebody went to the emergency room, somebody was admitted to the hospital, somebody had a primary care encounter, somebody had a test procedure. All of those claims data are near real time. They're transmitted near real time. And so having claims data available that is real time or close to real time and can be combined with clinical data gives you, and this is a term that's really important, the most complete longitudinal health record for individuals. That's what you're striving for in a data aggregation program, the most complete longitudinal health record. And the way you get that is by combining claims, clinical data, but claims have to be timely. They have to be fed from the payers on an up-to-date basis.
It's like we've had testimony that the claims isn't that.
I believe some of it said, well, yeah, you knew somebody filled a prescription, it didn't tell you if they took it.
Yeah, that's true.
There's limited.
So let's talk through that because that's really, that is very true. That's exactly why you need to combine claims with other data types to know the full impact on somebody's health and health status or a group's, a population's health and health status. So one of the projects we did, and I'll give you an example of this, claims is incomplete. It doesn't tell you about health status. Clinical data is also often incomplete. So I go to a primary care practice in Burlington, part of the Community Health Center. I see a GI doctor in an independent practice. I've had care delivered at UVM, and I've had to go to Brigham and Women's for care. And I've had to go to St. Albans for care. Not one of those providers had a complete longitudinal record for me. Not one. Not one. And this is recent. This is the last few months. Go to the emergency. So my point is that there's fragmented clinical data sitting in these repositories. And so you need to, number one, bring that together in the data aggregation program to get a better longitudinal picture. Number two, that clinical data is in and of itself not necessarily a complete picture. So let me give you an example. If you want to know how well primary care is doing on screening a population for colon cancer, colonoscopies,
Well, you need ability to have a 5-year look back. And people have moved, people change practices, people go to different places. The claims gives you, actually from the payers, gives you the best longitudinal. They keep track of the tests they paid for, the colonoscopies they paid for. You combine claims data with the clinical data, then I know that the most recent colonoscopy, no cancer, but I also know whether this person had colonoscopies periodically as recommended in preventive care. What are some of the most important quality measures? One of them is recommended in preventive care. It's a national set of measures. Any value-based primary care model is going to look at the rates at which people receive recommended in preventive care. If you have claims, like colonoscopies, like blood pressure screenings, if you have claims, you know that they have primary care visits, you know how frequently they were, you know where they were. You combine that with clinical data, you know if blood pressure is under control or not under control. You know if hemoglobin A1C risk for diabetes is under control or not under control. It's the combination that gives you the best health record. Let me stop there and see if that makes sense. It's a lot, but I'm
Yeah,
trying
no, it
to,
does make sense.
yeah. And so guiding legislation for a data aggregation program can require, and there are states that you would not necessarily envision that are requiring delivery of data into the data aggregation program. The HIE in some cases, and in other cases, the HIE plus a separate data aggregator. It doesn't have to be the HIE. And so it's really important to these payer data, attribution, socio-demographic claims, the clinical data, lab tests, procedures, diagnosis codes, test results, really a starting place. And if you don't have all that, if you don't have that data, complete data, your data aggregation program is going to be challenged. Your users are going to say, this is not accurate. And then you begin to get that fatigue or that fallout of the program.
Yeah, okay. My job is to keep you moving along.
Okay.
And I know we're asking a lot of questions, but
No. I would also, number 2, point that in guiding legislation, ensure that the state law and regulations allow for linkage of identified data. I think you do here now. For a long time, vCures was only de-identified. That was a problem. I was one of the heaviest users of vCures when I was running the Blueprint program, so I'm very familiar with what the data was like in there and how we could use it and not use it. And identity not being able to link with other data sources of the problem. So make sure that they can link identified data in the protected environments of an AHS data aggregation platform like the one being built now. That should not be a problem. And also, by the way, when you're thinking about data sets, AHS has a number of data sets that, in addition to payer claims and clinical, extremely valuable. Establish a time frame to have this operable. If you're going to enter into the next value-based care model, and hopefully we do as a state, it says the AHEAD model, and we've got a year to a year and a half of planning. Is this data aggregation capability going to be in place to support the participants in the model, to support the payers, the hospitals, the primary care that are, and the community service providers that are part of this in Vermont? So think about a timeline. Setting a hard goal for data aggregation capabilities to be available to support that program is something that's very helpful, especially as leadership changes in different environments. I talked about this earlier. It's one of the bullets in here. Sure, the data aggregation program is treated as a program, not as a technology or a data project. You need leadership with the expertise, like we talked about earlier, on using the data, and this idea of a leadership council that is part of the governance of the data aggregation program. Those are 2 things that really help to get engagement and have people willing to share and use data. Assure that in the plan, there's adequate and sustainable funding so that this data aggregation program is considered foundational. The starting and stopping is, I can't tell you how many states have dropped out of data aggregation programs because 2 years comes along, budget change, priorities change. And people have invested time and millions of dollars, and then they drop out because priorities change. You need a pathway, and you need, as part of the planning for this data aggregation platform, what is going to be sustainable funding. Maybe it starts with state funding, like the platform at AHS that's being worked on, and maybe over time there's a requirement to transition to multi-payer contributions to sustaining that
platform.
And does the cost remain fairly constant, or is it heavier at the beginning and then it sort of levels off, or?
Yeah, the build is always the heaviest. You know, when you're starting with a blank piece of paper, it's tough sending forth, right?
Yeah.
But you've got that underway, the contract that AHS has with Deloitte, they're working on the project. What is surprising for many, many people in the States is that ongoing funding is actually sometimes a little higher than they envisioned. And that's why getting multi-payer support for it over time, multi-provider support for it is really an important part. Otherwise, you're living hand to mouth. And why do I say that? Well, because the feeds that come in, simply the feeds that come into a data aggregation center, the interfaces that your hospitals have with Vital, the interfaces that primary care has to deliver clinical care to Vital, the way in which payers want to not only deliver data to your platform, but also get data from your platform. Remember, they have to have a value case out of this. The interfaces change, vendors change, and so you need constant maintenance of the feeds and the use. And that is something that has to be considered in the plan for a data aggregation program. And so that I think is really one of the most important parts. And so a sustainability plan is critical to driving not only engagement, but adoption of the tools. People aren't going to use something if they think it's going away in 12 months. The last bullet point here is assure that the data aggregation program is accountable. It's again, think of it as a program, not a data project. It's a program that is going to support all your providers across the state and your payers, your community service providers, people like SASH. Think of the full realm of people this can support, and then make sure that program is accountable. Do they have a dashboard and a monitoring system where they are giving feedback to you on a regular basis, to the state leadership, AHS, to the board? Are people able to see what this program is doing, what adoption and use rates are, and the impact that it's happening? So I'll give you a simple example. In Arkansas, we did CMMI did a data aggregation program with Arkansas. And it was the HIE in Arkansas, which is contained in the state government there. So similar to AHS building a data aggregation platform here. One of the innovative things they did was deliver a simple report to primary care on all the patients in their practice regularly who had a hemoglobin A1C test result, what the result was, and who didn't, who needed one. It was a one-page, literally snapshot with the people on it. Didn't deliver it to the doctors who don't open these things, delivered it to the care manager in the practice who does. The adoption rate on that was extraordinarily high. Why? Because everybody in the state participating in the model had an incentive and a priority to improve hemoglobin A1C results and diabetes control, getting to the outcome.
Right.
So reduce the risk of metabolic disease, reduce the risk of diabetes, improve hemoglobin A1C. Okay, deliver a snapshot. When they did that, and we were able to dashboard it for CMMI. CMMI could see that their investments in this data aggregation project was leading to changes in hemoglobin A1C control across the state. Medication management. You made the point earlier, and I was waiting for this part to talk about it, about knowing a prescription was filled, but did the patient use it, right? We're never going to know about adherence. I actually developed a medication adherence program back in Los Angeles as part of the inner city asthma program, where kids actually use their asthma meds or not. Really hard to monitor whether they're actually using it. But what you can know is what we call potential treatment days. So if you fill a script for something that you're supposed to use every day, and you only fill it 6 months of the year, your potential treatment months are 50%. Your potential treatment days are 70%. Your potential treatment days are 90 or 100%. And then you are able to cross-map potential treatment days against clinical outcomes. And that is a really good proxy for whether people are likely using their medications. You won't know for sure, but you'll have a pretty good idea. They have the medication, and their health status is changing. Therefore, this is having an impact. Does that make sense?
Yeah, well, also, if I have a 90-day script, and I only fill it every 180 days, I'm not taking it every day.
Exactly.
There's a, yeah.
Exactly. And that's why that claims data for medication bills is so valuable, because it lets you know things like potential treatment days. So one of the areas we work with in CMI's data aggregation program was Western New York and Buffalo. They have a great HIV data and very innovative. And we developed a medication management report for primary care. Again, not a massive thing, literally a snapshot. Here's all your patients who are on 2 or more high-risk medications in the elderly. There's a standard set of definitions for high-risk medications in the elderly. We told them, here's the 10 people in your practice who are on 2 or more high-risk medications in the elderly, and here's the ones that are on branded medications where there's a generic option. Quality, they're on high-risk meds, this is threat to health, and cost. Combined it in a simple snapshot, the adoption rates were extraordinarily high. You couldn't do that without the claims data.
Okay.
Does that help?
If somebody is on a controlled painkiller, and they're given a script for 20, they have 2 refills, but they keep going back after they've run out of refills, and they're trying to get a new refill after only like a week, and they're only supposed to take 1 a day. And obviously they're going to get rejected and denied, but are those attempts somehow could be integrated into the system? Because I see this as a way of potentially tracking people who are selling medications.
So it's a great question, and there are places, states. I'll stick with the state examples that have done monitoring, and it really ties in with your prescription drug monitoring program, which is a formal place where you're supposed to track scheduled medications. Right? The state of Nebraska actually requires all reporting and prescription drug monitoring to be available for use by their practices in their HIE. It's really an interesting example, but you can do what you're describing. The question goes back to these foundational elements at the base of the stack. Do the stakeholders involved decide that's a compelling use case, a business reason? And are they willing then to do the technical capabilities that take that prescribing data and turn it into the top, which is a 1-page report on the people who look like they have an overuse pattern, or overfill pattern with medications? If you work through those elements, then that could be a use case. That's where the Leadership Advisory Council is critical, and that's where the program leadership is critical. Is that a priority use case for your stakeholders?
So it sounds like pharmacists or pharmacies would have to be stakeholders and have buy-in.
If you're going to work with medication data, I will tell you, PharmD is there. At my own clinical experience, they're such valuable people to have on programs like this. PharmD, if you're using medication information, they really understand it in a way that doctors like myself don't. So yeah, it's very helpful if they're on it. So let me stop there. Those were key elements for the data aggregation program. Those are the sub bullets that are in this document here. And you can think about guiding legislation that addresses some or all of those, but getting those foundational elements right, the program leadership, the governance structure, requiring a roadmap to sustainable financing, making sure there's no legal obstacles to using identified data in the new data aggregation program. This is where guiding legislation is so powerful to help advance a real, and Vermont's been working on this for a long time. So we've had fits and starts and upticks, and there's been successes, and then there's been backtracks. The same thing has happened in many places around the country. It's not unusual. Guiding legislation is really crucial if you're going to set a course that's going to live through leadership.
Senator Lyons wants to make sure we talk about the blueprint and primary care and how we measure outcomes. How outcome measures can happen.
Okay. All right. So, all right, we'll back up to the primary care section. So if we want to think about primary care, and I know you're calling for an increased investment in primary care. And I don't know how far you'll go in terms of outlining what that investment looks like or not. As you probably have discussed in this group, there are a number of places in the states that are requiring an increase in the percentage of total cost of care that goes to primary care. That's a way in many states right now are leading this type of course. You've got a great foundation here in the Blueprint program and the medical homes and the community health teams, the hub and spoke program for opiate addiction, SASH, the Women's Health Initiative. You've got a great foundation here for advancement primary care, working with these community support systems. I mean, even 2 years ago, you put the increased investment in mental health providers integrated with primary care. That's happening and practices are adopting that. So you got a great foundation, but you got to make sure that this investment translates into, I call it the ground game, actually reaches the practice, reaches the providers, increases the staffing, increases people's access to the services that they need. They don't have to wait 6 months to get into a primary care practice. You need to, so when you talk about monitoring, and this ties right back to the data aggregation program, you need to make sure that you are aggregating the data that's going to let you know that people are using primary care and that there's a change in that, and maybe even the frequency and the rate for high needs groups, how often they're seen in primary care, the proportion of the population that actually has access to a primary care and says they do, and it is not delayed. So what do you have to do in a data program to monitor that? You not only need the clinical and claims data, because that'll tell you a lot about who's using primary care, but that patient experience data. How are you going to get that? Well, there's a standard CAHPS, it's called CAHPS survey process. It's a standard national patient experience survey. You probably have gotten them in the mail sometime if you've gotten care. AHS in the Blueprint, we started using a medical home, which is primary care oriented CAHPS survey many years ago. Don't know if they're still doing it or not, but that should be one of the data sources that contributes to your data aggregation program. You should be able to combine patient experience with clinical health and know whether those two things are changing as your investment takes on. That is an example of how your investment in primary care ties to your data aggregation program. Does that make sense to you?
It does make sense. It seems like our workforce shortage kind of could skew some of a lot of this, just as.
It's an influencer. And so, if you make an increased investment, how does that increased investment, let's say you go to 12 to 15% of total cost of care instead of 6 or 7% or 8%, which is where it is now, depending on what definition of primary care you use, or broad or narrow. If you go up in that investment, that should translate to changes in staffing. It will take time. But if you can pay more social workers, you're going to have more social workers. If you can hire more community health workers, you're going to have more nurse practitioners. So monitoring workforce is actually another part of the data aggregation program. Is it going to happen instantly? No. But do you expect it as part of the ROI on this increased investment in primary care? You should. And if you were to see flat rates of these people that work in primary care and in mental health, licensed counselors, if you see flat rates, even though you're investing more and the access doesn't change, that's how you monitor. And you have to know that, and you should know that trend early, so that next year in this session, the next year, you are actually have reports in front of you that help you have that insight.
We need more housing first.
So you can
Whatever.
Yeah.
So you can tie your data aggregation program to the investment in primary care. But the other thing is requiring that these investments are used to improve the ground game is another part of the guiding legislation. That the number of primary care clinicians, the number of clinicians for mental health and substance use disorder are tracked and reported. And do you have expectations? Maybe you're not ready to set benchmarks right now, but maybe you're ready to call for guiding legislation that they deliver the data so you can track and then develop benchmarks as experience is gained in the program. Think creatively, because if you're going to make that investment, it should go to the ground game. In the Blueprint, when I was leading it, I could walk into any independent primary care practice and talk to them and did.
And they knew where the money was going. They knew the money coming in from the blueprint was never enough. They knew the community health team staff was good. They loved their social work. We got the stories. When you walked into the practices that were owned, particularly by larger hospitals, primary care docs didn't know where that money was going.
Yeah.
They did know their community health team staff because they knew they had a social worker to call now or somebody to call. So requiring that this increased investment is translated into the ground game and people delivering services, and that's going to be monitored. You don't have to tell them how, you don't have to tell them who to hire, but setting up the ability to monitor it so that every year as you come back and consider this, you do know what the changes are is critical. And advanced primary care programs that do this well are the ones that are more likely to have an impact. So that monitoring is really critical. And I would argue that also ties back to your payment model. So it's one thing to say we're going to invest in primary care. We're going to put more dollars in primary care. Well, how's that going to reach the practice? So one of the links I gave to you here is to National Academy of Sciences, National Academy of Medicine report on how to build a strong foundation in advanced primary care. It's an elegant report. It was published in 2021. Most importantly for you folks, it outlines what has been found over 10 years of experience. And I would argue, I would reinforce that as the key elements in a payment model. So you can think about not telling how the payment structure works, but the key elements that need to be considered or included in that payment model. It's not just increasing the investment. How does it reach? So I'll give you the three major grouping components of a primary care payment model. One is upfront capitated payments that are predictable with primary care practice. They're not going to hire people. They're not going to change their operations unless they have a predictable revenue stream. So like in the AHEAD model, CMS through Medicare is giving somewhere $18, $19 per person per month. Every practice knows they're going to have that revenue. They can structure their operations and plan their budget with that reliable revenue source. So upfront capitated payments are a crucial component. Second component, some places still include a very small fee-for-service component. Right now, it's the major component. So everything is done for volume. There are a lot of folks who have experience in this that believe a small fee-for-service component is still a bit of a volume incentive. So yes, the majority of your payments up front, you can design good operations, but you still have an incentive to give access to people and make sure they get in. So I think Medicare was thinking of a $50 per encounter type of payment on top of the capitated. So you're combining those two. And then the third component is a performance incentive. You're going to have a set of accepted standardized measures that are really important to you. Maybe they're reflecting access, they're reflecting quality, they're reflecting health status, blood pressure control, diabetes control, people who have access to mental health services. You get your priority set of measures, and at the end of each time period that you choose, maybe it's annually, there is a performance incentive based on the outcomes. And that ties right back to attribution. You can't do this payment model and measure the outcomes unless upfront you have that clear attribution from each payer as to who's responsible for this patient. Then you can measure the trend. Does that make sense to you?
Yeah.
Those are key ingredients. And what I would show you really quickly, I included in the materials. This is a publication with the Milbank Foundation that I put together with a Dr. Howard Happ. Howard led Maryland's advanced primary care program. So Maryland's the other state besides Vermont that frankly was considered upfront for the AHEAD model. And they've got over 20 years experience with hospital budgets. They're way ahead of it.
Updated on there.
Yeah. Okay, well, Howard led their primary care model. So he and I were asked to write an outline of considerations for states. And what I want to point you to for your legislation, there is an outline here of priorities for state-led programs that have kind of emerged as critical for advanced primary care. They're in a table. These are the elements. And you'll notice.
Link to this, sorry.
Yeah, you have the link
This one?
and I also sent you the electronic version. I'm happy to send it again.
Okay.
Yeah, and the link is on this as well. So it runs you through a whole set of considerations that you could think about including language around some of these, maybe not all. But there are recommendations for, guidelines or requirements. And they're detailed, then the discussion goes into detailed language, which some of this language may be helpful for your list. Takes each of those elements and discusses them in detail. And so this may be helpful for you. This is why we were asked to write this, because these have emerged as just core elements. And it goes into the payment model, it goes into the care delivery elements in the model design. AHS and Green Mountain Care Board are going to be leading on an initiative such as this. They both have different roles. Regulatory role of the board and hospital budgets is, that's top line for the board. But they also need to know what the plan is, where if we get control over these hospital budgets and we do have some savings there, are the investments in primary care likely to impact and improve outcomes for people? Are we seeing a shift in emphasis from maybe some overpayment in hospital care, which the data suggests there is right now, to primary care? And is that translating into workforce access, health outcomes, and quality? The board and AHS need to work together and coordinate tightly on this. This is where the rubber meets the road.
It seems like they need to work together and their roles need to be really clearly defined at the same time.
Well, I couldn't agree with you more. If you turn to the first page on the very first bullet that I laid out for you, is titled "Improve Coordination and Clarify State Leadership Roles to Guide Effective Transformation." And in my mind, after just having and seeing the discussions and what's happened recently, so reaffirming the essential roles of the board and AHS may be very helpful. They're complementary roles, and they need to work together, but reaffirming the regulatory role and the program. Remember, AHS is not only a program leadership role, it's a payer, Medicaid. So reaffirming those roles and considering, I know there's been some discussion I've heard about an office for planning, healthcare leadership. I would just say my bias, my experience is you have really good people here. What you need is a better coordination of the leadership. So consider formalizing a joint leadership committee calling for a joint leadership committee between the Mountain Care Board and AHS. Again, the governance issue. They meet, they're required to form this formal leadership council, and they are required to deliver coordinated plans for the various elements that are included in here, each with consideration of their own role. The Mountain Care Board's not designing health service models and programs and not a payer like Medicaid. AHS is not a regulatory body over hospital budgets. Their roles can be fairly distinct, but boy, do they need to be tightly linked together.
Mhm.
So that's why I put it as the first bullet here to answer that question, because if you notice the theme I'm trying to bring to play here, it's that governance and leadership is where everything here starts. I don't care if it's the data aggregation program or frankly leadership on the head model. It's the same need. And so if I was designing that, I would consider a joint leadership committee that is formalized and required to plan, coordinate together. And they're sharing the monitoring that's coming in the same use, that's the use of the same data that's coming out of the data aggregation program. So one can't complain, we have different data than you or the other. They're sharing the core measures. They've agreed on core measures. They're being produced out of the same common data. There's trust in the process, and they're able to use that information to plan. So that was, to me, that was top bullet.
Yeah. Awesome.
And then this primary care model is more likely to work because the board can say, we can expect changes in hospital budgets. Let's say they tie hospital budgets to Medicare reimbursement rates, which in the data we're working with, we have a group of people, actually a broad range of people working together on this Vermont Healthcare 911 Coalition. And we've taken national data from the National Association of State Health Plans. We're looking at comparative data across all hospitals in the country.
And we can see where we have opportunities to control the budgets here. It turns out our administration and management costs are higher here than they are in other places across the country. We have clear data on that. The Green Mountain Care Board is in a position to set a benchmark that you need to operate. I'm just using this as an example, to Medicare reimbursement rates by year 3, which is not an unreasonable thing. When we look at 107 academic medical centers in the country, all over the country, 80% of them are operating at Medicare reimbursement rates or better. Only 20% are losing quote unquote money on Medicare reimbursement rates. We should be able to get closer to that. We are the 6th largest loss to Medicare reimbursement rates in the United States with nationally comparative data. Why? What's driving that? It's not the direct care delivery labor costs. Those actually look very similar to other academic medical. The data tells us we're okay with, we need to maintain. Don't cut services you don't need to, don't even consider that. Where our opportunity is in the non-patient care labor costs, and in particular, management and administration. And if your Green Mountain Care Board is going to get to the point of setting those kind of budget goals and benchmarks, which they could, they need to be working closely with AHS to make sure these services are monitored. We don't lose services. In fact, they improve maybe. Primary care changes. This needs to be a coordinated effort. That's why this joint leadership council, instead of a new office with new bureaucracy, new layers, new expenditures, you've got good people that formalize this work.
Yeah.
Let me stop there and see if that thing makes sense to you.
It does. It's great. I was wondering if you might be able to weigh in on reference-based pricing and all.
Yeah. So it's a term that we're all, it's being used widely here. It's used widely across the country. The example I gave you is an example of reference-based pricing. What it means is that
When you say that example you gave us.
Medicare reimbursement rates, for example.
Oh, just now.
Yeah, that's one example. So it means you're choosing some benchmark or some reference of payment to tie your budget requirements to. And there's a number of, you could use national averages, you could use a number of different types of benchmarks and say, we're going to set our hospital budgets to meet these benchmarks. One that seems to be working well is tying to Medicare reimbursement rates. I would have thought that was a problem years ago because Medicare reimbursement rates are always described as low.
Mhm.
Well, as I mentioned, it turns out that about 80% of the academic medical centers are operating, breaking even, or gaining revenue on Medicare reimbursement rates. You already have your state Medicaid agency benchmarking their payment to Medicare rates. You already have that. You are well along the path, but getting the hospital budgets in line with that and having a reduction in unnecessary expenditures there offsets the investments you're putting into primary care and will lower commercial rates. So, for example, in 1 year, UVMMC claimed in their national reporting $119 million loss to Medicare on reimbursement. Well, they made up for that loss on what they charged Blue Cross Blue Shield, which translated into the commercial rates that every business and family is paying in the state. If they didn't have that loss, that 1 year measure alone, 2 years ago, of $119 million gives you a lot of room. There's more in there, but if the AHS planning an investment in primary care and the board planning this budget aren't working in sync, how do you do the complete financial model and make sure you're measuring access and quality and health to see whether the changes you're implementing are maintaining or improving people's outcomes at the same time that they're getting better control of cost? Does that kind of framing?
Yeah, it's super helpful. We've had really great discussions.
That's awesome.
Yeah.
Good, thank you. Keep going.
I think they talked.
We did, but I will point you to this Milbank article because
Yeah.
it does go through every one of these key elements, and there may be language in there that is helpful to you. So it starts with this table, and for each of these elements, it gives some bullets, but then it goes to a deep discussion and deeper discussion. And some of these may be considerations for your primary care model, but It's really critical that if you increase investment, you have some expectations on the payment. And that also you actually have some expectations, and it's the last bullet in this paper I gave you, on payer participation and hospital participation. When you enter into a value-based model like this, if you don't have enough payers participating or hospitals participating, the model will not work.
Mhm.
There's no primary care practice that is going to change their operations, or hospital is going to change their operations if only 30 or 40% of their patients are involved in the model. And they still got to work on 40, 50, 60% of patients in fee for service and generate the same old revenue. You need critical mass with payer and provider participation. And that leads to the last bullet of in here that I've highlighted for you. That's why the first one was the coordination between the board and AHS. And I offered the idea, Senator Lyons, of formalizing a joint leadership committee between Green Mountain Care Board and AHS, requiring a coordinating formalized leadership committee to do their planning on.
It's in the draft,
And then
something that we had talked about earlier, but
Right.
you're affirming what our goals are.
Yeah. And then the last bullet is requiring hospital and payer participation. This critical mass issue, and what I mean by that is having enough payer and provider participation so that their whole population is involved, or the majority of it, and they can change operations. That is a linchpin to models around the country. We had that challenge in the all payer model. You've lived through it. So how there are, and I remember back to the blueprint, one of the things that launched the blueprint in 2000, from where it was as a pilot in 2008 and 2009, going statewide, was that the legislature was willing to require payer participation in the primary care payment model and community health teams. And when that passed, that really launched expansion statewide. And the requirement, the legislature that my bosses in state government told me was, you get Medicare to do this because they'd never done it before. And then we'll require our payers to participate. It was an all payer drive. We did get Medicare to participate for the first time in history with any state led initiative. And then the legislature was willing to require the payers here to participate. Well, the dynamic's different now. You've got CMMI that's coming forward and saying we'll participate in these models, but you state, we're not going to tell you how to do it. You bring along your payers. And the states that are having, like Maryland, that are having the most success in engagement and participation, it's because in some way they have required participation. For their hospitals, they have to participate in their budget process. They have for a long time. Well, now they're setting requirements in payment for primary care so they can advance primary care. So think about that last bullet too as part of your legislation. I don't know if you have that. If you do enter in a model, I don't think want to be in the same situation as before, where you have 30 or 40% of the population represented in a value-based model. Let me stop there. It's a lot of information. I'm trying to give you the supportive documentation with some languages in it that may be helpful as the go forward.
Senator Cummings, go ahead. Yeah. Reference-based pricing this year's new panacea. If we just go to it, everybody will pay less and get more. We've got one hospital that's profitable. Everybody else is in different shades of red.
Yeah.
If we pay them less, I think that's my concern. I think I'm hearing you talk about an organic system where they may also be required to provide less service because more service will be switched into primary care and but I think
I see what you're
we've lost the federally qualified health center. I think the people that like reference pricing would be a lot less enthusiastic if they had to travel 50 miles to find an emergency room. And so it's trying to find that balance with shaky hospitals.
So we thought about this a lot and trying to do some of this work with the Vermont Healthcare 911 initiative, and then we were looking at data on all the hospitals and where the opportunities are lying. Number one priority, do not cut services so everyone or access to services. Can you control costs better without cutting services? Fundamental question. The answer, and this is striking to me, and I'll tell you why in a moment, is yes, you can. And the reason that you can is because in the national data that is available, and it's good data, we are in constant contact with NASHB about whether we're using the data right, not using it right, it's reported right. They've been in contact with UVM. There's discussions back and forth that have happened. That data tells us that we have a high cost of labor for administration and management at a number of our hospitals. Not direct care delivery personnel. We don't have to affect that. Our savings opportunity is we're top heavy in administration and management. So to answer your question, the board is going to be able to do the job they need to do in getting these hospital budgets under control. There really is a cost opportunity, and it's not in care delivery or cutting services. When I read the Oliver Wyman report, there's so much good information in that. And I'm thinking there was, the narrative that came out of that was so much about these 4 hospitals and do we need them and this and that. And I started looking at the numbers of those hospital costs in the national data. You could shutter those 4 hospitals today, close them, never pay another dollar to any of those 4 hospitals. And what you would be doing is moving all those people into the most expensive administration and management costs in the country. So my thought to you on that is set the budget. The Green Mountain Care Board could do this if they work with AHS closely. I'll give you an exact example. Work on a 3-year plan to get the hospital budget where it's operating close to or in alignment with a reference. In this case, I'm offering you Medicare reimbursement rates that they can manage to that cost. Why? Because the data says 80% of the academic medical centers in the country do that. And good ones. I mean, you guys should go take a look at the data. Really good ones.
When you talk about the 3-year plan, are you talking shared for all the hospitals or UVM?
This is where we come into.
Yeah, so I know that you and I talked about this, and my original plan was to look at the 5 largest hospitals and to look at how reference-based pricing would influence them. In fact, Rutland has already sent me information about their reference-based pricing. So some of these hospitals are doing this. So it's a matter of coordination, standardizing, and building a system that's predictable within the board process.
Can I also just get this answer though?
Sure. No, and that's exactly right. So my recommendation is that you certainly set our largest driver, UVMMC, on that road to where they're operating closer to their peers in terms of their budget. Each of these other 5 hospitals that Dr. Lyons is talking about may be in different positions to where they're reference-based. And this is where AHS should be working on a transformation plan with them. And then the board can set hospital budgets that are more in line with the particular needs of the hospital and the community. This doesn't have to be everybody exactly the same. This is where coordination between AHS and the board is so critical. And so it may turn out that Rutland and has already done some changes in their way they're paying for care. They may have other opportunities. It may be different than where Northwestern is, for example. That is individual planning, but set the benchmarks based on the individual needs. So you need the health service experts at AHS working with the hospitals to inform the board, and the board using that information to set budgets. They don't all have to be the same, but there is tremendous cost opportunity without cutting services. And quite frankly, when the response to a little more, and I will say little more rigorous budget effort by the board last year, they were a little tighter. When the response was to cut services, that triggered a lot of people. And it helped lead to this coalition of people who never stood on the stage together. Business leaders, ex-governor, business roundtable, unions on the same stage together saying, wait a minute. And the data says there is a cost opportunity. This is the core of your question. And you do not need to cut services here. And maybe the footprint of what some of the smaller hospitals do does transform, but that can be planned over time appropriately. That's a health service planning, but you can also have the board working on budgets that move certainly our largest hospital and several others more toward this reference, whatever the references they choose. I happen to be using Medicare reimbursement rates as the example.
And the references have to be the same for all.
Not necessarily.
Okay.
You may find, you would find pushback probably from the board on, oh my God, I got to do all these different models for all these different.
Right.
So they probably will want a common benchmark. And what's happening in states that are using Medicare reimbursement rates as a benchmark, it's multiples of the Medicare reimbursement rate. So maybe one hospital, our largest, 80% of the academic medical centers get down to management at Medicare reimbursement levels, and they're not cutting services. Maybe that's the reference point you use for them. And maybe for other hospitals, it's 150% of Medicare reimbursement rate or something like that. You can adjust, you can turn the dial and tune that budget process, but it should be informed by the transformation plan that hospital has in line. This is where that joint leadership council, so it isn't ad hoc. It's actually done as a formal process, could be so valuable. Does that help answer your question? Helpful. Because none of us, me included, I spent 20 years in the academic medical center. I mean, I built a career there. I love what academic medical centers do, and I want a great academic medical center, and we have wonderful people delivering care at this academic medical center. We also happen to be very expensive and have the highest commercial insurance rates in the country, or some of them. We have both. So that's what leads to the question, can you get control of our hospital budgets with operating services? And the answer in the national data is that you can. So I think most people would share those priorities. Most people I talk to do, including providers at UVM. I will also have one point in my whole career, which is, I'm old now. A long time working on these national value-based models, advanced primary care, data aggregation. Nowhere at CMMI, CMS, anywhere did they ever talk about cutting costs. The theme of all these models has always been slowing the rate of growth in healthcare costs. Always. That's been the mantra. Nobody with any expertise believed you could actually cut costs, myself included, till I ran into this day. We can cut costs in one sector of our hospital care here and invest in other sectors. We actually can. It's in the math, it's in the numbers. I wouldn't say it if I didn't know it, and if that data hadn't been verified by the source of it, which is NACM, it's not us. It all comes from Medicare cost reporting. Medicare requires it. The data doesn't get used the way it should. So we can actually cut from one sector, lower commercial rates, get more in line with the rest of the country and our commercial rates, and invest in primary care. I would offer the data suggest that there is a volume there. And that's not a volume you're going to get by shuttering small hospitals. That isn't where the leverage is here.
Yeah.
Is there opportunity to change a footprint and some of the services and how they're provided? Sure. But people need those hospitals in their communities. Maybe the footprint changes or the profile of services. But that's not the answer to our cost growth. And that's not the block on our ability to invest in primary care. It's that our money is going to reimburse what is called a loss to Medicare and reimbursement into our commercial rates.
Amazing.
So this has been terrific.
Mhm.
I know that it's kind of bringing it down to the level where it sounds like we can do something that helps people.
Yeah.
Because we're always talking up here with policy. We understand we have to have policies broad enough that we're not squeezing any organization or individual, but this has been really good. We've talked before. Great.
Really, really excited that you all are taking these things on consideration in your legislation. And it's time for Monty exists. It's the right time. I think everybody's gotten to a kind of an inflection point.
Everybody's finally gotten to a good point.
Yeah.
Pain's bad enough. So, so I think what we're gonna do right now is take a real short break till 10, and then we're gonna bring Jen up and we'll have a conversation about where we are with our little framework. And I can't thank you enough for being available today and for the difficult day on Tuesday. He was here for 3 hours or 2 hours, 2.5, or whatever it was.
Poor Kiki had to.
Just, yeah.
Were you online or?
Well, we
It was
were
right here. It was right here.
just ready.
While we were on the floor, and I thought we'd
Oh,
get down
right.
here in time, and we didn't. So they really,
Yeah.
and this is not a good travel day. I get it. I just talked with someone who drove from Franklin County and said that there were multiple accidents around
Oh.
Colchester and other places.
Yeah, it was a little slippery.
The ice was horrible.
Yeah.
Um,
Thank you. I just want to thank you for giving me the opportunity to talk to you.